northwest of England in wider workforce, but actually has been working within the Greater Manchester system on training and education for as long as I can remember. I'm just going to talk today to you about PCNs as a learning environment. So over to you, Jill.
Thanks, Joanna. I'm just going to share my screen. She says so confidently. So like Janet's just said, she's new, I'm new to this particular role of AD, and my whole remit is to try and quality assure placements in primary care for the wider workforce. So hopefully this will be a bit of a whistle-stop tour. There's been lots of changes over the last 6 months, and I've tried to unpick the maze and give you the sort of key points, maybe identify some learning needs that I've identified over the last 6 months and I can share with you. I will answer, if you put questions in the chat, I'll answer the questions over coffee because I'm a one-man band. So taking you forward, what I want to do, I want you to think back 18 months ago when you first started to think about PCN, started to think about how that might look, what your population health was, and then suddenly COVID came along and everything got kiboshed, and we're in a whole completely different world. But actually the real positives have come out of this with the COVID vaccination centres. We're working together, multidisciplinary teams are working together, we're all learning together. You know, we're wanting to get to the end of this pandemic, but we've got a shared vision and a shared goal, and that's what we need to capture, because that is what learning and supporting each other in a PCN is all about. So I have to do this cell slide. You probably already know all these different things, but the benefits of primary care networks being involved in training, nursing and allied health professional, raising the profile of primary care as a long-term career option. We know years ago the Valois paper about medical students coming out into general practice then increased them choosing general practice as a career option, and what we need to do is the same and get involved with our undergraduate nurses and AHP placements. Providing a positive role model to encourage medical student, nursing student, foundation students to pick that career option, so they see the GPNs, they see the GPs in practice and they think, yes, that's what I want to be. We know recruitment within training practice is better. We tend to have less vacancies in training practices, and you're starting to grow your own. You're starting to retain your existing workforce and expand them and develop them. We know good clinical markers linking with those in training practices, where we're all thinking as a team how to train and learn, but it keeps us up to date. And that diversity in the team as well gives us that opportunity to think around problems differently. Looking at developing the additional workforce and our current workforce as well, which comes out of those opportunities when we realise what's going on in the wider field. And working as a PCN, those smaller practices who may not have been able to take undergraduate nurses because their practice nurse was only in part-time, could start to actually work as part of a PCN, so that undergraduate nurse, that undergraduate paramedic, whoever it is, could rotate around several practices during that placement, so everybody gets the benefit and that undergraduate student gets the experience of primary care. So the NHS long-term plan, it tells us we're going to get 6,000 more GPs and we're going to get 26,000 additional roles. But actually the reality is not quite that. This slide is taken from a paper that was produced 2 years ago when we were still talking to look at the trainee nurse and associates. But this is our GPN's retirement in the next 5 years. And you can see from different CCGs, between 30 and 50% of our GPNs are due to retire. And looking at the workforce data from November, the GPN workforce over the age of 55 is 33.6%. So we've not really made any impact into this yet. We still have a workforce that is due to retire in the next 5 years. And we mustn't forget, we've got these workforce additionality roles, but actually we mustn't forget to develop our own practice nurses. They're great ambassadors, they're great leaders, and we need to develop their skills to help them feel part of the team as well. national GP workforce data, just to really make you doom and gloom. It's not rocket science. All these lines are going down. And again, in Greater Manchester, we've got 15.35% of our GPs are over the age of 55. So we need to work together. We need to make these opportunities work, but also make our workforce feel valued and loved. So why be a clinical supervisor? Okay, the chance to teach best practice, share your skills, ensure that existing knowledge imparting to the future workforce, all those things about role modelling and mentoring. Is that really valuable skills. Our nurses, they have to, the nursing profession is one step ahead of GPs. All nurses have to have supervisor qualifications and have to revalidate against those. And we need to make sure as GPs that we give our nurses that opportunity to use those skills and then develop them into a practice assessor if they want. Shared learning opportunities, we've seen that with our COVID vaccine, how valuable that is. Upskilling our workforce, improving patient care and outcomes for our patients, and developing the management and leadership skills of those individuals and empowering them to take those next steps. So who can supervise who? It's a minefield. So GPs can supervise GPSTs, they can supervise FY2s, they can supervise physicians associates. Advanced practice, they are at master's level, and if they're at master's level, then they can supervise the wider workforce, the AHP groups. And then our nurses can supervise, a GP and an AHP can supervise a nurse, but they can't assess nurses. The NMC requires nurses to be assessed by nurses. So it's a bit of a minefield. We used to, for those of us who are used to GPs or used to GPSTs and used to FYs, that we're used to that one route. But actually, there's a whole workforce out there that we can use. And some of you have seen this, that HE, the GP school, Northwest has provided this trainer journey and shows you the different routes that are available. So the 1A is the wider workforce in primary care, clinical supervision, that we're running with the Northwest training hubs, and that's a 2-day course that's aimed to supervise the wider workforce. The 1B option is the foundation supervisor course, so again 2-day course designated completely to foundation supervision. There's this second bit of the journey. If you've done 1A or 1B, you can then do a 1-day course to supervise GPSTs at a clinical supervisor level. And then the third route is what we traditionally know as the basic trainers course, where you can become an educational supervisor for the GPSTs. This is just a very simple basic overview of that in that slide. So current processes to be accredited learning environment, we've got lots of different things out there at the moment. So the GP school will approve you as a learning environment to take GPSTs or FYs. The training hub will approve you to take the wider workforce. So whether that's undergraduate nurses, whether that's paramedics, they will approve you to do that. The only thing that the training hubs don't do is the medical students. The medical school has a separate process and they approve their own learning environments. And then any of the apprenticeships, the clinical apprenticeships above level 4, so any of those that involve the universities are required to have a learning audit done to approve those environments. Any apprenticeship levels below level 4 are not actually required to do it. It's a request, but it's not required. So where were we going? This is where we are now. We have multiple different learning environments. So you can be a GP training practice, and then you can take medical students, and you still have to have your learning environment approved by the medical school. You can be a GP training practice, and you still have to have this multi-professional audit tool completed if you want to take undergraduate nurses. And there's all kinds of people that feed into that. So the GPSTs and the FY2s, there's training program directors and there's associate deans. The multi-professional audits, the training hub, have practice educator facilitators, nurse educators, and then these university link lecturers. So it's a minefield of different processes for different learners, and then throw in the apprenticeships, which all have slightly different things as well. And it really is a huge maze. So where are we going to? There is a vision that the GP school and the training hubs will all form part of a primary care school, which will include all the allied health professionals too, and actually we'll have one process to approve a learning environment. And this is what I've been tasked with, and the training hubs have been tasked with, to deliver over, to start to deliver. This documentation came out in September, but start to look at how we make a primary care just have one process and not multiple processes depending on the learners. And this looks a busy slide, but it's very simple really. There's two different routes that are proposed in this paper. Route 1, which is the left-hand side, that's for those that are already accredited as a GP approved or an FY2 approved learning environment. And then there's going to be an application process that you could then add, if you wanted to add another learner from the wider workforce. You would complete that application, and that would go through the GP school, and be agreed the number of learners that could go in that environment and be ratified. There is paperwork to be filled, and there's 6 domains that you need to fill to do that. The route 2 is the bit that actually I think is the more exciting route. So that's now looking at the primary care networks or federations being the learning environment. And the documentation is the same, but for each bit of that, so each practice or whether you want to use a local pharmacist, you want to link your optometry, you want to link care homes into your learning environment, so that your trainees within your environment can then have almost a hub and spoke placement, and they can learn all about how the primary care network works together. And that will then be submitted through the training hub. And at the moment it's probably going to be a virtual thing, but that training hub will work with the associate dean for that patch to accredit those environments and start to work together. With any of these things, there's some teething problems, and at the minute we're trying to work out how the GMC fits together with it, and then it will be how the allied health professionals and their recognised accreditation processes fit through it too. But that's the vision, and that's where we're going. And hopefully then that will save time and stop duplication of multiple visits, but also will allow the networks to develop into the wider primary care and not siloed into different little routes, so that our students get the exposure to all of primary care and its benefits. I'm just going to feed into, and I know Paula and Joanne are going to talk to you in the next presentation about this, but I wanted just to sort of clarify the workforce additionality, how that's going to fit in, and how they have their supervision needs as well, and how we're going to develop and make sure we travel this in the right direction. Some of you might have heard of a roadmap to practice, and these have been written. The first one came out in November for the first contact physiotherapists. The paramedic one is due out sometime soon, and it's trying to help clarify the education for practices moving from the first contact practitioner roles and onward into the advanced practice roles in primary care. It defines what a first contact role is and what the training and the pathway is, and likewise what the advanced practice roles are, and then how they build that portfolio of evidence for those roles and take it forward, and then the linking of the supervision and the governance, which feeds into HEZ's Centre for Advanced Practice. So there's some busy slides, but I'm hoping that this will help clarify what we're doing. So as you know, there's pre-registration, they come out, they've done their whatever their specialist degree is, and then they need a minimum of 3 years. Once they've done that and started to develop that breadth of experience, then they can go onto the first contact role and start looking. And there's two ways to do that. That can be either by a portfolio or HEIs of the universities, for which at the moment UCLan and Cumbria University do. But obviously with this expanding workforce, this is an area that's expanding. And then once they've got their first contact role and they enter into primary care, then they can start to looking at the advanced practice role. I've mentioned about this and I'm going to whip through it, but it's basically a database of who can supervise. And this has been tweaked at the moment. There's hot off the press, different ways of verification. And this is the sort of hot potato at the minute. But what is a first contact practitioner? Okay, it's a clinician working in primary care at the top of their clinical scope of practice. They are a band 7 and they are at the minimum threshold for undifferentiated, undiagnosed conditions in primary care. There is a recognition process, and a slide that I'm going to show you in a minute will show you the 4 pillars of advanced practice, but the FCPs are starting to work at the clinical pillar of their practice. So the physiotherapists or the paramedics, they've developed their breadth of experience clinically, and they have demonstrated that they are at that level before they're able to move on. And then advanced practice, they have 4 pillars of advanced practice, and it's master's level that these guys are working at. So the 4 pillars of the research, the leadership and management, education, and clinical practice. And they're working at a band 8 and above, 8A and above for that. This slide is really busy. I've put this in for you to read later, but again, it's just highlighting that transition. So these first contact practitioners are starting to get involved in audit and research and starting to contribute into the supervision, whereas the advanced practitioners, thinking of those 4 pillars, are demonstrating audit and research projects, and they're demonstrating that they can clinically supervise and educate within those roles. Portfolio of evidence. Again, they build that evidence whilst they're working with you to demonstrate those competencies. So looking at the first contact practitioner role, the first bit, the very first simple bit, and you'll hear people talk about stage 1, is demonstrating the knowledge, skills and attributes and what they need to work in primary care. And they need to evidence that before they start working in primary care. And then stage 2, they can only do that when they've completed stage 1 and must be completed in practice with a specific period of time. And they can build that portfolio of evidence, or they can do the HEI course and then become accredited as first contact practitioners. The assessment tools are very similar to those being used for GPs. So those of you GP trainers will recognise all these different assessment tools that will be as part of that process. So again, busy slide, but what I want to pull out on these slides is that there's differences between clinical supervision and CPD for supervision. And some of our professionals, when they're talking about clinical supervision, are actually really talking about CPD supervision. And the CPD supervision runs along the clinical supervision, but both need to be the responsibility of the employer. The CPD, it must be provided by the employer. The clinical supervisor role needs to be provided in that clinical setting. So that individual that's being supervised has daily contact to be able to debrief and make sure the patient and the practitioner are safe. The clinical supervisor takes responsibility for the patient and the practitioner's safety. And as I say, we talk about those different pillars, but the clinical supervisor is responsible to make sure there's an induction program, there's day-to-day supervision, learning needs are identified, and you start to develop those clinical reasoning and critical thinking and populate the workplace-based assessment. Whereas the CPD supervision is really more along the professional regulation and revalidation and making sure that they are within their professional scopes of competency. Finally, educational supervision, that is sort of an evolving thing. Traditionally, for the wider workforce, this was done by the universities, but now this is going to sort of start to evolve into the primary care training hubs and linking with the Centre for Advanced Practice. Your local training hub, I think you've all met Carol, she's done presentations for you before, and the locality hubs I've listed there. So if you haven't come across your locality hubs, those are the ones that break down into. There's a couple of resources that I've put on there. The e-learning for health is great. It's a toolkit. It tells you what qualifications, what requirements are required for each of the different roles in primary care. And the HE star is useful when you align it up. If you're looking at the slightly different roles and you're looking to see, has this been done before? There's documentations and resources there. Okay, whistle stop tour. We are going to now break out into breakout groups. I understand that you've all got the documentation to know which breakout group you're going to go into. And you're going to, with the facilitators, I want you to start looking at where your workforce is now and where it's going, and could a learning supportive environment help this plan? We'll come back in 15 minutes and we'll feedback through the chat. Okay, does that sound like a plan?
Thanks very much, Jill. Now, I think everyone's got their instructions about how to enter their breakout room. Please shout out for help in the chat or by popping your microphone on if you're not sure what to do next. But you should, as part of your